Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasato. Dr. Biasato is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasato for Delaware Healthcare Reality.
Hello, this is Dr. Nick Biasato. I am the host of the MSD's podcast, Delaware Healthcare Reality. Today I have a very special guest, Dr. Shalini Shah. Dr. Shalini Shah is a practicing physician with Dover Family Physicians. She's chairperson of the Department of Family Medicine and the Director of Undergraduate Medical Education at Bay Health. She's a Medical Society treasurer. She's a clinical assistant professor in family medicine at Philadelphia College of Osteopathic Medicine and clinical associate professor of family medicine from Jefferson Medical School. Dr. Shah did her undergraduate education at Penn State University, and then she received her doctoral degree from Drexel University College of Medicine. She then obtained a master's degree in public health from the University of California in Berkeley. She is a board-certified family physician and is certified in lifestyle medicine and the American Board of Obesity Medicine. Welcome, Dr. Shah.
Good afternoon.
How are you?
Good. How are you doing?
I'm good. I'd like to ask you a few questions, and you answer them appropriately and as you can. How did you develop an interest in obesity and weight gain?
It was a personal journey. I've always been interested in preventative medicine from about 4th, 5th grade, and then prevention threw me into the career path that I've chosen throughout my life. And then I personally saw how an unhealthy weight and or obesity had caused difficulties within my mom and my relationship with weight since I was about, adolescence on up. And it was continuing to be an issue personally. And then, of course, as a physician, we see how it impacts our patients' health and day-to-day living.
By definition, what is obesity, and how do we determine if a patient is obese?
So the best way to determine obesity, and there are multiple ways, but the cheapest and fastest way is through what we call a BMI, body mass index. And that is taking your height over your weight, and it is in the metric system. And anything that is above 30 would be considered obese. So normal weight, just to bring it down to what a normal BMI would be anywhere from 19 to 24.9. 25 to 29.9 is considered overweight, and then 30 and above is considered obese. Now, we do further break that down into class 1, class 2, class 3 obesity. We are really trying to get rid of just obesity and morbid obesity because there's a lot of bias to that word morbid. So class 1 obesity is going to be 30 to 34.9. Class 2 obesity is 35 to 39.9, and then class 3 obesity is 40 and up.
Okay. Where does waist measurements? I hear that's a new way to determine obesity and hip to waist ratios.
Yep. There are different parameters for those, and that can be also included in the definition of obesity. However, for insurance purposes, and if you are trying to get any kind of medications for your patient, the BMI is still the gold standard. And so when it comes to waist circumference, for females, it's going to be 88 centimeters. And then for males, it's 102 centimeters. When it comes to the waist to hip ratio, which really is measuring abdominal obesity, and that does have specific increased health risk associated with that. The normal typical conversation of apple versus pear-shaped body type, and that for a female was going to be a ratio of greater than 0.85, and for a male greater than 0.9.
Now we have scales. We just measure a patient. They stand on a scale. You flick on, you go through it. It's either automated or you got a little thing. You run over there and gives you the weight. That's not as accurate as an in-body scale, which seems to break down your body from its muscle to fat all through the body. I have some very I have patients in the male and female category that are weightlifters. And by definition, on a BMI, they may come out as obese when in essence their muscle mass is equal or to or greater than their fat mass. Do you consider that when you are considering how you're going to treat the patient in an in-body scale, which I think is much more accurate than the others.
Well, again, the BMI is the one that's used most often because it is the cheapest and it's the most widely available. The in-body scale is going to be something that is only available at certain locations. So yes, with the electrobiopedance, that does help to differentiate how much of the weight in kilograms or pounds is attributed to muscle mass versus fat mass. Unfortunately, that is not widely available. Those units cost, and I did look them up, it costs anywhere from $7,000 to the high end up to $15,000 to $20,000 per unit. And this is usually not reimbursed by health insurance.
Very good. Okay, what causes a patient to be obese? Is it genetics? Is it overindulgence? Is it both?
Just like in everything when it comes to life, it's always multifactorial. So I don't want to use the word overindulgence because I do think, again, that has a lot of bias, and I don't think that is the majority of Americans. There may be a sub-selection of that, but when it comes to overall, there is a multi-component to it. We have already really determined that there's multiple hormones that are involved with obesity. There are these hormones that are stimulating and inhibiting food intake, such as the AGRP and the NPY, and then the POM-CART hormonal inhibitions that can happen, and they do play a role with our food intake. And then, of course, we have our metabolic hormones that are also involved. So this is a complex issue, and just like with anything that's complex, it's going to be taking a multifactorial approach to try to address what is the epidemic of obesity in the United States.
How does obesity affect patients' health and well-being as well as their longevity?
It can affect in numerous ways. And you did mention this in your previous podcast that I did able to listen to, which was quite interesting. And it can affect by just increasing the risk of certain health conditions, diabetes, coronary artery disease, strokes, increased risk of blood clots, obstructive sleep apnea, venous insufficiency, depression, anxiety, low self-esteem, clotting disorders, and also including some musculoskeletal complaints like osteoarthritis.
The knees can't take it anymore,
The knees can't. And then there was a study done, you were asking about life expectancy. There was a study that was done, a meta-analysis done back in 2009, that showed that a BMI of 30 to 35 decreases the life expectancy from 2 to 4 years. If you increase that to 40 to 45 BMI, which remember that's class 3 obesity, so we went from class 1 to class 3, then the life expectancy decreases to 8 to 10 years.
Now that we start to understand some of the mechanism leading to obesity, how can we, 1, change a patient's habits? 2, are their dietary programs successful in producing lasting weight loss? I'd like you to distinguish some of the fad diets, if you can, from the effective diets, such as Weight Watchers, Nutrisystem, Keto, Mediterranean, intermittent fasting. I could name them on and on and on. Can you make some comments on that? And then we'll go to the psychology of weight loss.
Wow, you're opening up the big can of worms
big
there.
Can of
big
worms.
Can of worms, yes.
I've been told that before.
Dietary habits are really, really important to address. Whether or not, in my approach to weight loss or to achieve a healthy weight, you need to look at non-pharmacological options, and dietary habits are really, really important. These different weight programs, what is successful is trying to tell patients a solidified dietary habit pattern. People like to just be told, tell me what to do. However, the success of these are going to vary depending on how limiting these dietary patterns are. So if you have keto diet, Nutrisystem, Weight Watchers, Mediterranean, intermittent fasting, they all incorporate some sort of limitation. And if that does not go with what you want in your life, you are eventually going to not be successful. Because, and I explain this to my patients all the time, if you do a type of pattern, and I don't like to use the word diet. This needs to be an eating plan. This is going to have to be the way you're going to have to eat for the rest of your life. And so if you're not willing to commit to a keto diet for the rest of your life, then you're not going to be able to succeed in having sustained weight loss.
But aren't all, I'll say, diets limiting?
It depends on what your perspective is and what are your goals when it comes to your eating plans. Overall, some of them are going to be restrictive in terms of the type of calories. However, is it going to be restricted based on the food types? Is it going to be restrictive in just the quantity types? Is it going to be quality? Is it, Weight Watchers, really how they work is that they are saying that you can eat anything, but you do need to watch within the calories that they're subscribing. And they use a point system. And then when it comes to Nutrisystem, again, that is a calorie system where they are encouraging you to buy their foods that fit within their dietary patterns. But they really do encourage that you can have any kind of food. Now, keto diets, they're going to be very, very low in carbohydrates. When we talk about Mediterranean diets, that diet, when it comes to health, the Mediterranean diet is considered one of the best dietary patterns out there. But we're talking overall health. We're not talking about specific weight loss. So when it comes to, and again, the Mediterranean diet, just in case some of your listeners don't know about it, is high complex grains, limited meat, using a lot of nuts and berries and seeds to help with your good omega fatty 3 fatty acids, lots of fruits and vegetables. Along with, there is actually a physical activity component to a Mediterranean lifestyle, which is incorporated in that, which of course that's not talked about when we talk about the Mediterranean diet. But the more restrictive you have in terms of your eating patterns, whatever diet you may end up picking, and I put diet in a quotation mark, if it's too restrictive, you're not going to be able to continue with it. The grapefruit diet, which I think was probably a big fad when I was in elementary school, but I can probably do a grapefruit diet for about a week, but am I going to be able to sustain that? I'm going to lose weight with that because it's a very limiting diet, but is that sustainable? In addition, just having one type of food is going to put me at risk for other nutritional deficits. And we see this. We see people who are at a very unhealthy weight, class 3 obesity or higher, that may be calorie overabundant, but can be very nutrient deficient.
You did mention the Mediterranean diet has some exercise with it also. How important is that in maintaining our weight? Should we exercise 3 days a week, 4 days a week, aerobically, anaerobically? What do you think?
So again, there's not going to be one shirt fits all sizes when it comes to helping with weight loss. And there are numerous studies that show that when it comes to weight loss, and I understand you said weight maintenance and not weight loss, and actually that is a key differentiation. So when it comes to weight loss, physical activity does not help. And it makes sense. If you ever go on a treadmill and you see how many calories you burn in a half an hour, if you're lucky, maybe 150 calories if you're doing it in moderate intensity, and that's if you're lucky. I can look at half of a bagel and I would get that much back, right? So it's inconceivable to be able to lose a 500 calorie deficit with just physical activity. And I try to talk to my patients that physical activity has 175 different reasons to do it. Cardiovascular health, but it's not going to, and depression and so many other reasons, but it's not going to help with weight loss. Where it does play a huge role is going to be weight maintenance. So once you're able to achieve a healthy weight for you, and that should be determined by you and your physician, then it will help to maintain that weight. And usually it's going to be a combination of cardiovascular along with strength training. And I'm kind of segueing a little bit away from this, but there are 4 components when it comes to physical activity. There's cardiovascular, strength training, balance, and flexibility. Now, balance and flexibility does not play as much of a role when it comes to obesity, but there are obviously numerous health benefits to having those components of physical activity. But when it comes to strength training, that does help. We're talking mildly increase your metabolic rate. There's no way that's going to increase it by 10%, but it does help a little bit. And then cardiovascular is going to help with keeping up, using up the energy. And that the goal is, by American guidelines, is 150 minutes per week.
I remember when I have friends in Germany and I stayed there for some time, and they brought me breakfast, and it was the Italian prosciutto, French cheese, a loaf of bread, and a cup of coffee. And I said, how do you guys stay so skinny? Well, one of the reasons is they took me in town, and there must have been 1,000 bikes in town, all chained up, and while people worked. They all rode bikes to work. They all did activities. And their lunch was a little sandwich, but dinner was very small because you're going to be laying down, and that's got no way to get burned. So the old attitude, calories in, exercise them out, doesn't seem to fit the picture. Okay, thank you. Now, do you use in your practice psychotherapy or some way of behavior modification? Do you have a nutritionist tied with you in some way who he or she can, give some behavior training to people about how to eat?
Unfortunately, we don't have a specific nutritionist that we work with because unfortunately with the way the health plan insurance companies are, it is unfortunately, and this is the frustrating part, they won't pay for nutritionist counseling. And then if they do pay, then of course it's going to be who they want to cover. So even if I have a great working relationship with a nutritionist, that may not be a covered benefit. They may not be in their network. But I do try to work with them. There is a couple of podcasts that I recommend my patients to listen to because it's a skill set. Just like with anything in life, there are some skill sets that they can learn, learning to recognize what true hunger is versus what emotional hunger is, and knowing the difference between the two and getting more in touch with their body signals, along with developing some sort of eating plan that's going to work for them that they're going to be able to sustain with.
Now, there's an issue I think that's pretty out there now, and everybody's asking and asking. What role do medications play in assisting sustained weight loss? For example, the phentermine Topamax mixture, the amphetamine and the amphetamines themselves, newer agents under the class of GLP-1 glucagon-like peptide agonist, and the GIP, glucose-dependent insulinotropic polypeptides. What do they play a role? How do they work? Are you using them? I know that they're flying off the shelves in the pharmacies. You can't even get them. They're so popular. What do you do in situations? Tell me how you use them.
I use it as a toolkit in trying to help my patients achieve a healthy life.
How do they work?
Well, they work in different mechanisms. So, you're talking about several different classes of medication. The amphetamines, and that would include not only the stimulants like Vyvanse, which is used for impulse control. It can be used for ADD, but in this setting, it's for impulse control, and that is a eating disorder. And then you also then have phentermine alone, which is an appetite suppressant, and then you have the combination medication called Kisamaya, which combines phentermine with Topamax. And they really work on different mechanisms. You have an appetite suppressant, while Dopamax works on some of those hormonal systems that I already talked about that can help decrease the sensation of wanting to eat. There is a true addiction when it comes to for some individuals when it comes to food. If you talk to someone who has been dealing with a weight that's not healthy for them over years, and I personally have experienced this. Back in 2019, I had my highest weight at that time was almost 180. And then in 2020, I had a wake-up call. My hemoglobin A1C, which I always knew was an issue, finally became that diabetic range where it was at 6.8, and I knew I needed to make some changes. And I always had the skill set. As a physician, I knew what I needed to do, but it was hard for me to be able to implement it. And these medications can really help with all the food chatter that some people may have when they are dealing with obesity. So when it comes to those medications, that's how some of those work. When it comes to the GLPs and the GIPs, they really are working with all the different hormones that are involved with our weight in terms of our satiety, our appetite. It works with helping to slow the gastromotility of our GI gut. It increases certain hormones, which then helps with satiation. It helps lower the emptying rate of the stomach. There are some side effects, which we'll talk about later. And then there was one other medication you didn't mention, which is Contrave. That is a combination of bupropion, otherwise known as Wellbutrin, and naloxone, which is a common medication that's given for opioid overdose. And this, again, is working on those addiction patterns.
The addicted patient could do well on those as opposed to something different.
Mm-hmm.
Okay.
Yeah.
So you have to really take a good history, find out what their eating patterns are, why they eat. And some people say, I love to eat. I love to eat. And, some people eat to live. Some love to eat, as the expression goes. Okay. you've told us how they work somewhat. And then when you reach, I see it as giving a patient some right up front satisfaction of weight loss. In other words, it didn't take them very long to start to lose the weight. And they see it going, and it makes them happy, and it makes them feel better about themselves. I have a grandson who is obese by definition, and class 2, I would say. And he was 14. He didn't like his body. He didn't like the way he looked. Put him on Wegovy. Tried it out. 35 pounds in 3 months. He now feels better about himself. He's changing in his eating habits because he was one of those people that loves to eat. Not just to sustain himself, but love to eat. And he is now psyched and now exercising more, feeling better about himself, and restricting when he says, I'm full. Now, do you get into a situation where you have to maintain them on some of these newer agents, these injectables? Can they use them the rest of their life as quote-unquote maintenance? Or when they reach their goal, you hope that they now have a different eating pattern? How do you view that whole thing?
Well, this is unfortunately new territory, correct. Uncharted territory. At this point, it is maintenance also. These medications are shown to be needed for maintenance. Does it help with making other lifestyle changes? Undoubtedly. But is there going to be a potentiation of weight gain if you reduce and or discontinue the medication? Absolutely. There can be a potential risk. And this is really uncharted territory. But counseling your patients, telling them what to expect, providing them with the support, again, telling them about the skill set that's going to be so important to make sure that they understand that it's just like riding a bike. You have those initial training wheels, and then if their expectation is that they want those training wheels to be off, which is the medications, and then they're going to just continue with their lifestyle modification, then they may need some extra assistance, and to have some compassion and grace, because we're all human at the end. But just remember, I like to compare this to depression. We don't tell someone who's depressed, well, just do behavioral. Forget about the medications. We don't do that. And there is an element of bias if we're doing something different when it comes to obesity. We need to consider medicine as a tool within our toolkit to help our patient. And again, there is non-pharmacological options, there's pharmacological options, and then there's surgical options. And bariatric surgery is time and tested. Data has been out there now for 30 plus years showing its efficacy. Now medication use, it started first with fen-phen. There might have been more medications that preceded me, but fen-phen is the one that I remember. And then, of course, the newer medications that are now just recently in the last 5 years been out in the market. And then there is orlistat, which I forgot to mention that is another weight loss medication. Really have fallen out of favor because it causes a lot of GI side effects. And the weight loss is not that great. But that is still an option. And unfortunately, it's still on formulary to fail before they would accept other medications. So I just wanted to put that out for your listeners.
What are some of the contraindications for the use of these GLPs and GIPs?
Well, I was going to talk about all of them because I don't, right now the sexy meds are the GIPs and the GLPs, but I do want to also know that there is still Contrave and Kisamaya, and they do have very good data behind them too. So for specifically GLPs and GIPs, it's going to be the increased, mostly it's going to be GI side effects, and those are going to be the most common.
Well, I'm talking contraindications now.
Contraindications, yes, you did.
And
sorry.
not side effects. We'll get to that.
So contraindications, really, other than a family or personal history of thyroid cancer, and or a family or personal history of a neuroendocrine disorder.
Well, there wasn't the thyroid cancer issue in mice and not in humans.
But that is still, that's going to be a shared decision making, but I would tend to not do it. Got it. We are a very litigious society.
And then the multi-endocrine neoplastic syndrome. Yeah. And the side effects.
Oh, and history of pancreatitis.
And history of pancreatitis. But that's one of the side effects also of these agents. Tell me about some of the side effects now that we've passed the contraindications.
So, there are some other contraindications for the other medications. So glaucoma history, seizure history, especially with Contrave or Kisamaya. So those are things and then phentermine also. So those are things to keep in mind too. and then uncontrolled hypertension. So in terms of side effects, again, GI side effects when you're talking with anything when it comes to weight loss, that involves the gut, you're going to have some GI side effects. And nausea, vomiting, abdominal discomfort, fishy burps are all common side effects. Constipation, yeah.
What do you do in a situation like that? You say, oh, you're having side effects. Do you persist through the side effects, or you cut it off, say, no, we don't use these agents any longer, provided you rule out pancreatitis or something like that?
Well, pancreatitis is going to be significant. I mean, yeah, this is, you're something's wrong. You're going to be like seeking immediate attention for this. But when it comes to the other side effects, it's going to be also, again, just like with any side effects, how bad is it affecting your quality of life? If they are having some mild ones, but it is causing a little bit of problems, I may keep them at whatever current dose they're on. It does show through time that some of those side effects will dissipate over time. And it's usually the nausea and vomiting that tend to be the most predominant symptoms. There are ways in terms of constipation. You can talk about making sure they're hydrated, physical activity, increased use of fiber to try to help combat sometimes the constipation too.
I'd just like to make a note that the GLPs and GIPs out there, and which ones are for only, they won't approve them for anything but diabetes, and that's the Mounjaro, Ozempic, and Rybelsus. They will not pay them for weight loss. However, Wegovy and Zepbound, Zepbound is Mounjaro in just a different name, and Wegovy is a GLP-1 agonist. They can only be used for weight loss at this point. The others are for diabetes. Now, we talked about when goal is reached, how do you maintain it? And you gave us some great answers to that effect. Dr. Shah, this has been a very, very interesting, educational discussion you've given us. You could see your knowledge just pouring out of your brain right in front of me. I think it's a good thing, and I appreciate you being here. Do you have any questions for me?
I don't, but can I just end with one little comment here? So Dr. John Forate, he made a comment back in 1995 that predicted that almost all Americans will be overweight or obese by 2230. He then updated about
5,200. You said
2230. So 2230.
Wow.
So then 10 years ago, he had to update it.
For sure.
And he says that by 2030, so
wow.
literally he
That's
moved
right
it up by
around the
200
corner.
years.
That's right around the corner.
He said almost at this current rate, almost all Americans are going to be overweight. And he says that by 2100, everyone will not be just overweight and obese, but will be just obese.
Wow.
So this is really
it's a scary stat.
It's a very scary stat, and it just kind of belays the point that we need to redefine what obesity is, the bias that's there, and also trying to make it more acceptable to be more encompassing with how we're taking care of obesity.
Thank you very much for a very, very, very interesting presentation. A lot of people will be interested in hearing that. At this point, our podcast with Dr. Shalini Shah is complete. It was very good, and any questions, again, you know where to go. This is Dr. Biasato. Further podcasts will be coming in the future. Stay tuned.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. Delaware Healthcare Reality is produced by Tom Mitten. I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the hosts or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.